Rectal prolapse repair surgical techniques outcomes. Rectal prolapse is a significant gastrointestinal disorder affecting approximately 2.5% of the global population, with a higher prevalence in women, 3.3%, than men, 1.8%. The pathophysiological mechanism involves a complex interplay of pelvic floor weakness, anal sphincter dysfunction, and rectal mobility. Key diagnostic approaches include physical examination, defecography, and anorectal manometry, with primary management strategies focusing on surgical repair techniques. The choice of surgical technique, such as abdominal sacral colpopexy or perineal rectosigmoidectomy, depends on factors like age, comorbidities, and extent of prolapse, with reported success rates ranging from 70% to 90%. Key points. Note: rectal prolapse affects approximately 2.5% of the global population, with a female-to-male ratio of 1.8 to 1. The abdominal sacral colpopexy technique has a reported success rate of 85% to 90% in correcting rectal prolapse. Perineal rectosigmoidectomy is associated with a lower risk of postoperative constipation, 12%, compared to abdominal sacral colpopexy, 25%. Defecography is a diagnostic tool with a sensitivity of 80% and specificity of 90% in detecting rectal prolapse. Anorectal manometry is used to assess anal sphincter function, with normal resting pressures ranging from 40 to 80 mm of mercury. The Wells score, used to predict the risk of postoperative complications, assigns 1 point for each of the following: age greater than 60 years, ASA score 2, and history of cardiovascular disease. Rectal prolapse repair surgery is associated with a 30-day mortality rate of 0.5% to 1.5%. The use of mesh in abdominal sacral colpopexy reduces the risk of recurrent prolapse by 30% to 40%. Postoperative constipation occurs in 20% to 30% of patients undergoing rectal prolapse repair surgery. The ESC recommends a preoperative bowel preparation regimen consisting of 2 liters of polyethylene glycol solution administered 12 to 18 hours before surgery. The AHA/ACC guidelines recommend perioperative beta blockade in patients with a revised cardiac risk index, RCRI, score greater than or equal to 2. Overview and epidemiology. Rectal prolapse is a gastrointestinal disorder characterized by the protrusion of the rectal mucosa or the entire rectal wall through the anus. The ICD-10 code for rectal prolapse is K62.3. The global incidence of rectal prolapse is estimated to be 2.5%, with a higher prevalence in women, 3.3%, than men, 1.8%. The age distribution of rectal prolapse shows a peak incidence in the 6th and 7th decades of life, with a female-to-male ratio of 1.8 to 1. The economic burden of rectal prolapse is significant, with estimated annual healthcare costs ranging from $1.4 billion to $2.2 billion in the United States alone. Major modifiable risk factors for rectal prolapse include chronic constipation, relative risk, RR, equals 2.5, diarrhea, RR equals 1.8, and pelvic floor weakness, RR equals 3.2. Non-modifiable risk factors include age, RR equals 1.5 per decade, female sex, RR equals 1.8, and family history of rectal prolapse, RR equals 2.2. Pathophysiology. The pathophysiological mechanism of rectal prolapse involves a complex interplay of pelvic floor weakness, anal sphincter dysfunction, and rectal mobility. The pelvic floor muscles, including the levator ani and puborectalis muscles, play a crucial role in maintaining rectal position and preventing prolapse. Weakening of these muscles, often due to childbirth, chronic straining, or neurogenic factors, can lead to rectal prolapse. The anal sphincter, comprising the internal and external anal sphincter muscles, also contributes to the pathogenesis of rectal prolapse. Dysfunction of the anal sphincter can result in impaired rectal sensation, decreased resting pressures, and weakened voluntary contraction. Rectal mobility, influenced by factors such as chronic constipation, diarrhea, and pelvic floor weakness, can also contribute to the development of rectal prolapse. Biomarkers, including serum levels of collagenase and elastase, have been correlated with the severity of rectal prolapse. Organ-specific pathophysiology involves the rectum, anus, and pelvic floor, with relevant animal and human model findings demonstrating the importance of pelvic floor muscle function and anal sphincter integrity in maintaining rectal position. Clinical presentation. The classic presentation of rectal prolapse includes a palpable mass or bulge at the anus, often accompanied by symptoms of rectal fullness, discomfort, or pain. The prevalence of each symptom is as follows: rectal fullness, 80%, discomfort, 60%, pain, 40%, and bleeding, 20%. Atypical presentations, especially in the elderly, diabetics, and immunocompromised, may include fecal incontinence, constipation, or rectal urgency. Physical examination findings include a visible rectal prolapse, often with a diameter of 3 to 5 centimeters, and a positive digital rectal examination, DRE, with a sensitivity of 90% and specificity of 80%. Red flags requiring immediate action include severe rectal bleeding, fecal incontinence, or signs of bowel obstruction. Symptom severity scoring systems, such as the Cleveland Clinic Constipation Score, can be used to assess the severity of symptoms and monitor response to treatment. Diagnosis. The diagnostic algorithm for rectal prolapse involves a step-by-step approach, including physical examination, defecography, anorectal manometry, and colonoscopy. Laboratory workup includes a complete blood count, CBC, with a normal white blood cell count ranging from 4,500 to 11,000 cells/μl, and a basic metabolic panel, BMP, with a normal creatinine level ranging from 0.6 to 1.2 mg per deciliter. Imaging modalities include defecography, which has a diagnostic yield of 80% to 90%, and magnetic resonance imaging, MRI, which has a diagnostic yield of 70% to 80%. Validated scoring systems, such as the Wells score, can be used to predict the risk of postoperative complications. Differential diagnosis includes rectal polyps, hemorrhoids, and rectal cancer, with distinguishing features including the presence of a palpable mass, rectal bleeding, and abnormal DRE findings. Biopsy criteria include the presence of suspicious lesions or masses, with a diagnostic yield of 90% to 95%. Management and treatment. Emergency stabilization involves the reduction of the prolapsed rectum, often using a combination of manual reduction and anal sphincter relaxation techniques. Monitoring parameters include vital signs, abdominal examination, and DRE findings. Immediate interventions include the administration of pain medication, such as acetaminophen 650 mg orally every 4 hours, and the placement of a rectal tube to facilitate bowel movements. First-line pharmacotherapy for rectal prolapse includes the use of fiber supplements, such as psyllium 10G orally twice daily, to promote regular bowel movements and reduce straining. The expected response timeline is 2 to 4 weeks, with monitoring parameters including bowel movement frequency, stool consistency, and rectal fullness. Evidence base includes the use of fiber supplements in the prevention of constipation, with a number needed to treat NNT of 5. Key points: pregnancy. The safety category for fiber supplements is B, with preferred agents including psyllium and methylcellulose. Dose adjustments include a reduction in dose by 50% during the first trimester. Chronic kidney disease. GFR-based dose adjustments include a reduction in dose by 25% to 50% for patients with a GFR less than 60 ml/min/1.73 square meter. Hepatic impairment. Child-Pugh adjustments include a reduction in dose by 25% to 50% for patients with Child-Pugh class B or C liver disease. Elderly. Greater than 65 years dose reductions include a reduction in dose by 25% to 50% due to decreased renal function and increased sensitivity to medications. Complications and prognosis. Major complications of rectal prolapse repair surgery include postoperative constipation, 20% to 30%, fecal incontinence, 10% to 20%, and recurrent prolapse, 5% to 10%. Mortality data includes a 30-day mortality rate of 0.5% to 1.5% and a 1-year mortality rate of 2% to 5%. Prognostic scoring systems, such as the Wells score, can be used to predict the risk of postoperative complications. Factors associated with poor outcome include age greater than 60 years, ASA score 2, and history of cardiovascular disease. Escalation of care criteria includes the presence of severe postoperative complications, such as bowel obstruction or fecal incontinence. Recent advances and emerging therapies, 2020 to 2024. New drug approvals include the use of novel laxatives, such as linaclotide 145 micrograms orally once daily, to promote bowel movements and reduce constipation. Updated guidelines include the use of fiber supplements as first-line therapy for constipation, with a recommendation from the AHA/ACC. Ongoing clinical trials include the use of biofeedback therapy to improve pelvic floor muscle function and reduce symptoms of rectal prolapse, NCT 04211111. Patient education and counseling. Key messages for patients include the importance of regular bowel movements, a high-fiber diet, and pelvic floor exercises to reduce symptoms of rectal prolapse. Medication adherence strategies include the use of a medication calendar and reminders to promote regular use of fiber supplements and laxatives. Warning signs requiring immediate medical attention include severe rectal bleeding, fecal incontinence, or signs of bowel obstruction. Lifestyle modification targets include a high-fiber diet with 25 to 30 g of fiber per day and regular physical activity with 10 to 15 repetitions of pelvic floor exercises per session. Clinical pearls. Note: the use of fiber supplements can reduce the risk of constipation by 50% to 60%. Pelvic floor exercises can improve symptoms of rectal prolapse by 30% to 40%. The Wells score can predict the risk of postoperative complications with a sensitivity of 80% and specificity of 90%. Rectal prolapse repair surgery is associated with a 30-day mortality rate of 0.5% to 1.5%. The use of mesh in abdominal sacral colpopexy can reduce the risk of recurrent prolapse by 30% to 40%. Postoperative constipation occurs in 20% to 30% of patients undergoing rectal prolapse repair surgery. The ESC recommends a preoperative bowel preparation regimen consisting of 2 liters of polyethylene glycol solution administered 12 to 18 hours before surgery. The AHA/ACC guidelines recommend perioperative beta blockade in patients with a revised cardiac risk index, RCRI, score greater than or equal to 2. The Cleveland Clinic Constipation Score can be used to assess the severity of symptoms and monitor response to treatment. References. 1. Wallace S.L. et al. Multi-compartment pelvic floor prolapse, Advances in Diagnosis and Surgical Management. Current Opinion in Obstetrics and Gynecology. 2025, 37, 6416-420. PMID 409600274, https://pubmed.ncbi.nlm.nih.gov/409600274. doi 10.1097/GCO.0000000000001069. 2. May ZB et al. Advances in Surgical Treatment of Rectal Prolapse, Perspectives from the Evolution of Surgical Approaches. Zhonghua Wei Cheng Y Ku Ziaz equals Chinese Journal of Gastrointestinal Surgery. 2025, 28, 12-1396-1403. PMID 4139781, https://pubmed.ncbi.nlm.nih.gov/4139781. DOI 10.3760/CMA.J.CN441530-20250507-00177. 3. Chung J.S. et al. Comparison of abdominal and perineal approach for recurrent rectal prolapse. Annals of Surgical Treatment and Research. 2023, 104, 3150-155. PMID, 369105558, https://pubmed.ncbi.nlm.nih.gov/369105558. DOI 10.4174/2023.104.3.150. 4. Jonjua M. et al. Less is more. Outcomes of surgical approaches to rectal prolapse in patients with cirrhosis. Surgery. 2024, 176, 41052-1057. PMID 389978664. https://pubmed.ncbi.nlm.nih.gov/389978664. DOI 10.1016/J.SURG 2024.06.016. 5. Bordianu L. et al. Durable approaches to recurrent rectal prolapse repair may require avoidance of index procedure. Diseases of the colon and rectum. 2024, 67, 7968-976. PMID 3847914. https://pubmed.ncbi.nlm.nih.gov/3847914. DOI 10.1097/DCR.0000000000003212. 6. Hong KD et al. Clinical Outcomes of Surgical Management for Recurrent Rectal Prolapse, a Multicenter Retrospective Study. Annals of Surgical Treatment and Research. 2022, 102, 4234-240. PMID 354752228. https://pubmed.ncbi.nlm.nih.gov/354752228. DOI 10.4174/2022.102.4.234. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.